Everyone, and thank you for joining this dental learning webinar supported by SomnoMed. I'm Joe Riley, the Director of Content for Dental Learning. Our distinguished presenter, Gina Pepitone is with us tonight to discuss building an in-office dental sleep dream team. From the receptionist and billing coordinator to the hygienist and dental assistant, every employee should play an integral role in screening and managing of potential patients who might not know that they suffer from obstructive sleep apnea. In dental sleep medicine, a team approach is vital as each team member evolves with new roles and responsibilities to help obstructive sleep apnea sufferers. Gina is an RDH practicing with Long Island Dental Sleep Medicine, the only AADSM accredited dental sleep facility in New York State. On a daily basis, she works with patients, identifying risk factors, signs, and symptoms of obstructive sleep apnea. Gina has developed an online on-demand certification course, Certificate in Dental Sleep Medicine for the Registered Dental Hygienist, that is accredited by the Academy of Clinical Sleep Disorders Disciplines. This is the first and only certification course of its kind available to RDHs. In addition to treating patients and educating other hygienists, Gina lectures internationally on behalf of SomnoMed and various educational institutions, helping to advance the knowledge of dental sleep care professionals. If you have any questions during the presentation, please type them into the Q&A window on your screen. As many as possible will be answered during the course of the presentation. If you have any technical issues, type a note in the Q&A window and a technician will help resolve it. This webinar offers one continuing education credit. To ensure you receive your credit, please stay until the webinar has concluded. Early departures will not receive credit. Your certificate of completion will be emailed to you in about 2 weeks. Thank you again for joining us this evening, and now I turn it over to Gina.
Hello, and welcome to Building Your Dream Team. Remember, success occurs by design, not by accident. Today we will discover how balancing dentistry with dental sleep medicine can be productive, rewarding, and you may just save a few lives in the process. My name is Gina Pepitone, and I am currently working in one of the largest dental sleep medicine practices in America and the first dental sleep medicine practice to achieve accreditation in New York State. Every day I work alongside my amazing dream team, managing patients with obstructive sleep apnea, mostly in a clinical setting. We have grown our practice from one sleep patient a month to over 40 per month. I have been a registered dental hygienist for over 29 years, but grew passionate about sleep around 10 years ago when my husband, who was suffering from sleep apnea, was getting very progressively bad. He was a New York City firefighter recovering from 9/11 and was diagnosed with severe obstructive sleep apnea. For many years, I watched him suffer. He tried using continuous positive airway pressure, a CPAP machine, but was unable to wear it at night. After suffering night after night with choking, gasping, and loud snoring, I started researching alternative treatments, and I found continuous open airway therapy, oral devices that you can wear in your mouth that open your airway to help you breathe better when you're sleeping. This saved my husband's life, and it saved our marriage. Currently, there are about 22 million Americans suffering from obstructive sleep apnea. In 2015, a colleague of mine did a study in her dental practice in North Carolina, and what she noted was that 50% of her hygiene patients that she was treating screened high risk for obstructive sleep apnea. So in our dental practice, half of the patients that we see may possibly be suffering with a sleep disorder that we can help them with. Let's talk a little bit about how we can go from first contact with a patient and transition from that dental visit to giving them open airway therapy with oral devices. We'll start from that first contact, go through some questionnaires, how to interview our patients, what we can do during a dental examination. We'll talk about diagnostic testing and how to find out if our patients are diagnosed with obstructive sleep apnea, and then what to do after we find out their diagnosis, and how can we begin therapy to help them treating their sleep disordered breathing. You want to think about what you're going to do when you start bringing dental sleep medicine into your practice. You are going to be managing 2 practices. You are going to be marketing 2 practices as well. You possibly may need to add medical billing for oral devices, which is different than dental billing. You definitely will need some additional training. Time management sometimes can be an issue. Sometimes we think about maybe taking 1 day a week and dedicating that to treating dental sleep medicine patients. May be a little bit easier to focus on 1 day a week when you're seeing those patients than kind of mixing them in with your dental patients. Sometimes you need additional equipment, not much, but we'll go through that a little bit in the next few slides. And something new to dentistry is you're going to be collaborating with physicians. Most of your patients will have primary care physicians or sleep physicians that you're going to be communicating with during their planning of treatment. So how can you develop your own dream team? Think about who you presently have on staff. You're going to need your reception, you're going to need clinical staff, dentist, sometimes medical billers, sometimes third-party medical billing, and somebody who can kind of bring this whole team together, a dental sleep director, maybe somebody who takes care of the clinical portion and somebody who takes care of the administrative portion. Assign roles. So when you get back to your practice, think about who on your staff would do well in which position. Now, you may already have administrative staff. You're going to have to train them how to manage sleep referrals, how to acquire sleep studies, records, and prescriptions, how to call physicians' offices, how to talk to them, what to ask for. You may have to also talk about different ways of presenting fees because you're now working possibly with medical insurance, and analytics, how to kind of keep track of your sleep patients and maybe keep them separate from your dental patients. And then your clinical staff. Who is going to manage the patients who are undergoing continuous open airway therapy? Who can be that liaison for the device labs, who can communicate with the labs on how to design the oral devices, keeping track of when they're due and scheduling appointments, and then who is qualified to take impressions, digital or physical impressions, bite registrations, deliver the devices, make the adjustments. In some states, assistants and hygienists can do these procedures. In some states, only a dentist can, so you'll have to check with your local state rules and regulations. And then who's going to manage the referrals and the follow-up with your patients? Another thing to think about is who can be the liaison to your network of physicians. So as you start working with physicians and letting them know what you're doing with your patients, how you're treating obstructive sleep apnea, and building that relationship, who in your practice has the qualities to do that? It would be somebody who is very motivated, who is very passionate about the practice and encourages practice growth. Somebody who is strong enough to keep track of the sleep patients, maintain those protocols, keep up with education, make sure the staff continues learning about sleep medicine and other comorbidities related to obstructive sleep apnea, and somebody who can work with the team, the dentist, and the physicians. How are you going to build this infrastructure? We're going to talk about what type of screening tools to use, what type of patient education, what type of technology, possible software that you can add or you may already have, and how you're going to create those systems to follow. One thing that is very good for current patients to see is keeping brochures in the reception room and the operatories. Brochures that talk a little bit about obstructive sleep apnea and continuous open airway therapy, showing research about how continuous open airway therapy is an effective alternative to CPAP. In 2015, the Journal of Dental Sleep Medicine has a research study done by the Royal North Shore Hospital in Sydney, Australia, and what they showed was similar improvement in health outcomes, improving sleepiness, quality of life, driving performance, and decreasing blood pressure with oral devices and CPAP equally. Continuous open airway therapy can minimize the symptoms of snoring and sleep apnea. It is recommended for people who have obstructive sleep apnea that prefer it or cannot tolerate a CPAP. A CPAP is a machine that blows positive airway pressure into your airway to open your airway while you're sleeping. In a study, about 50% of CPAP users use their CPAP machine for 4 hours a night for the first 6 months. And then after the first 6 months, it decreases down to 17%. So after the first 6 months, only 17% of people that have a CPAP machine are currently using it, which leaves them about 3/4 or more of their lifetime of sleeping without any therapy. Oral devices, on the other hand, were shown to be used 7 hours a night for the first year, and after that, an average of 6 hours a night continuously. Studies show that patients prefer continuous open airway therapy because it is a comfortable, easy to wear, and portable therapy. It's easy to care for, easy to clean, very small, you can travel with it, and it does work. Side effects of continuous open airway therapy are generally minor and short-term, and they typically would be dental side effects, which is okay because we're working in a dental office and we can help treat those side effects. Questionnaires in your practice work wonders. Sometimes these questionnaires can be left in the reception area for patients to look at, but what I typically recommend is to start collecting different types of questionnaires, which we'll go through in the next few slides, and give them to your patients when you do their general health history updates and include them in all new patient forms. Questionnaires will ask about past histories of any type of therapy, if they have sleep apnea or if they've ever treated their sleep apnea, if patients are snoring, if they have any daytime sleepiness. A popular questionnaire is called the Epworth Sleepiness Scale, and it consists of 8 questions asking how sleepy you are in certain situations. For example, if you're sitting and reading, are you having a slight chance of dozing, a moderate, or a high chance of dozing off? Generally, people that score higher than 10 on an Epworth Sleepiness Scale are considered higher risk for sleep apnea. You can also have patient education materials in your operatory. So along with brochures with research and information, there are posters that you can hang up. Posters are great for your patients to see while they're coming in for their dental visit because it gives them a visual and it will kind of encourage them to ask questions about the poster, why it's there, what it means, and that'll give you opportunity to open up conversations about sleep apnea. We're going to stop for a minute and I'm going to show you a small video. On your right-hand side, you're going to see what's called airhead. This is a demonstration model that shows the mandible dropping back and closing the airway. It's a great tool to use to demonstrate to your patients what sleep apnea is, what happens when you're snoring. It's kind of a little silly when we show our patients, but it really does get them to understand what's happening with their body if they're suffering from sleep apnea or snoring. Another good thing to have in your operatory are demonstration models. I would recommend contacting as many device companies as you can and talk to them about the possibility of you treating sleep apnea in the future and ask for demonstration models. A lot of companies are happy to bring those models over to you so you have something to show your patients. And then they also can offer education about their oral devices and how they treat sleep apnea. You can get a wealth of information from the device companies. There are over 160 FDA cleared oral devices, and they come in so many different types. There are devices that are one piece connected together, monoblock, and there are some that are separate. There are some that have dorsal fins on the side that will hold the mandible forward. Some use telescopic arms. Some devices will have soft lining on the inside, which are great to use for people that have a lot of porcelain, bridge, and crowns. There are lots of different advancement mechanisms aside from the dorsal fins. There are fins in the front that anterior that will hold the mandible forward, and sometimes they will be separate, or sometimes they'll be attached, but they'll still allow to open the mouth. So I definitely would recommend researching lots of different oral devices and getting comfortable touching them, feeling them, keeping them in your operatory so that you can show your patients what they are and how they're used. Additional screening tools that you can use, easy things that you can keep in your operatory, are pulse oximeters. Pulse oximeter is a simple device that you place on a patient's finger, and it can read the content of oxygen saturation in the blood. Generally, to be healthy and for your body to function properly, you should have 90% or higher oxygen saturation in your blood. Most of the time when people have sleep apnea, that oxygen saturation dips down while they're sleeping. Another good thing to do is taking blood pressure. Hypertension is one of the highest risk factors for obstructive sleep apnea, so it's very important to check your patient's blood pressure at each visit. Another thing that you can do is measure their neck. Now, it's pretty rare that we're measuring neck sizes in a dental office, but there is actual research study that was conducted in 2011. It's published in the Chest Journal, and it shows that neck circumference is associated with the risk of obstructive sleep apnea. So generally, a neck size higher than 40 centimeters or 16 inches for women, and 43 centimeters or 17 inches for men are higher risk for sleep apnea. The way you would measure adjusted neck circumference is you would measure your patient's neck in centimeters. If they have hypertension, you would add 4 points to that number. If they are snoring, you would add 3 more points to that number. And if they've ever gasped, choked, or someone has witnessed them gasping in their sleep, you would add another 3 points to that number. If the number is greater than 48, they are at high risk for sleep apnea. If the number is anywhere between 43 to 48, they would be moderate risk of having obstructive sleep apnea, and less than 43, there would be a low risk of having obstructive sleep apnea. These are just good tools to have handy to open conversations with your patient and talk about the possibility of them having a sleep breathing disorder. There are also great applications that you can use on smartphones or computers that measure decibels of snoring and breathing during the nighttime. And then also measuring body mass index. So if you have a BMI that is 30 or higher, generally you are a higher risk for having obstructive sleep apnea. So these are a lot of very easy, simple tools that you can use in your office. Let's talk a little bit about technology. There is so much technology out there in the dental and the medical field. Every day it's changing and growing. These are just some of the more recent forms of technology that we use for our patients that have obstructive sleep apnea. So you're going to see in the upper right-hand corner, this is a remote-controlled oral device that you can use in a sleep lab. When a patient is sleeping, they're wearing this device in their mouth, and it slowly moves their mandible forward and back during deep stages of sleep to find a position where the mandible is forward enough to open up the airway and decrease the apnea. There's also a chip that you can place in oral devices that can record compliance to know whether a patient is wearing their device, how many hours they're wearing it at night, and also what position their head is in, whether they're lying supine or on their side, right or left, or prone on their stomach. There are devices called pharyngometers that you can use to measure breathing in a patient and map out the airway to see if they have good airflow. And then there are other things we can use, like cone beam computed tomography. This is a digital X-ray that can also map out an airway with 3D images. We can measure size, shape, volume of an airway while a patient is awake. And these are excellent education tools to show your patients what their airway looks like, what size it is, kind of explain how they breathe, why the airway closes, and also can help you to find additional possible anomalies that can affect the way that they're breathing. Things that you can see in their sinuses, deviated septums, any kind of pathology that might be affecting their airway. So with all this technology that you have now and all your screening tools, thinking about a patient who first enters into your office, what is the first impression? What does that patient experience when they enter your practice? Thinking about a new patient that calls on the phone, how are you going to let them know that you are now treating patients that have obstructive sleep apnea? Think about the verbiage that you're going to use when asking questions as a new patient. Are you going to dress the part? You definitely want to present an office that people can, when they walk in the office, they can see that the office is professional, educated, and very caring and compassionate. Make sure that your reception area is inviting, and it is not only dental, but sleep friendly. Get those brochures out there. Put some information about obstructive sleep apnea and how we can check for it in a dental office, how he can recognize signs and symptoms, and how he can help those patients. Think about the difference between your new patients and your existing patients. Your new patients, you have the opportunity to teach them all about what your office can do and all aspects of your practice. Existing patients are going to have to learn that you're adding new therapies into your office and show them what is changing and how that can be good and helpful for them. Bringing those forms and questionnaires into your practice on the new patient health histories and then on your recall patients, definitely adding those questionnaires in there. They take a minute or two to do, and they can give you a wealth of knowledge. Morning huddles. I cannot say enough about how amazing morning huddles are. How you start your day will directly affect the outcome. So think about reviewing all your patient charts, possibly the night before. Look at their health histories. Look at your patients' medications, what you've discussed in the past. Think about if they have any comorbidities that can be related to sleep apnea, like hypertension or diabetes, or taking acid reflux medications. Plan the next day to talk to those patients about their medical history. Think about the questions you asked before related to dentistry, now relate them to medical conditions and additional comorbid conditions. Know that history before they enter the door and go over it each morning with your staff. Present possibly one patient a day when you start to bring dental sleep medicine into your practice. Talk about what questions you can ask that specific patient that day and focus on one at a time and start slow. When your patient comes in for the dental visit, interview them. Talk to them about their health history. Again, review their medications. Instead of just placing new information down on your forms, ask them, why are they taking new medications? Exactly what are they for? How are they affecting the patient and the patient's function in daily activities and nighttime? Go over your questionnaires and try to develop conversation techniques. Ask permission to talk to your patients. Really sit down and listen to them. Look at how their emotions are developing when they're talking and try to figure out how you can help them with whatever is concerning them. Try to correlate the symptoms that they are feeling to any disease or disorders that they may have and show them how you can help them with that. During your clinical examination, try to connect what you're finding in the oral cavity to obstructive sleep apnea or snoring or whatever symptoms that they're feeling. Creating value is very important. Showing your patient that you care and educating them and letting them make their own decisions along with your guidance is very important. Show them that you have successful outcomes. Let them know that it's not only them that may have these conditions or symptoms, but there are other people that you've helped. Let them feel comfortable and guide them to the next step. During your clinical exam, there are a lot of anomalies that you will see in the oral cavity that you don't really think about as related to obstructive sleep apnea. But let's talk a little bit about palates. Very high arch, vaulted, narrow palates can be shown to have a patient who has difficulty breathing through their nose, sometimes snoring, sometimes a little difficulty with oral breathing through their oral cavity as well. Lingual sides of teeth, if you're looking at them and you see any kind of acid erosion, Generally, they would be on the anterior, maxillary anterior teeth on the palatal side. Acid erosion can be a sign of acid reflux. Acid reflux is a very common symptom that is comorbid with obstructive sleep apnea. Look at their mandible and their maxilla and look for tori. If you see large mandibular tori or even palatal tori, think about where the tongue placement is. And if that tongue doesn't have anywhere to sit comfortably in the oral cavity, where does that tongue go? Does that tongue possibly drop back into the pharynx and prevent the patient from absorbing enough oxygen, especially when they're sleeping? Also, look at uvulas and tonsils. Is the uvula inflamed? Is it red? Is it large? If that uvula is inflamed, could it possibly mean that a patient is snoring or their mouth is dry and they're having difficulty breathing? Look at your tongues. Now, you're doing generally an oral cancer exam and you're checking each patient's tongue. Have you ever noticed the scalloping along the lateral borders of the tongue? Why does that scalloping occur? Is that patient's tongue too large to fit inside the oral cavity? Could that be a risk factor for obstructive sleep apnea? Absolutely. Large tonsils blocking the airway. Retrognathic profiles. Think of class 2 occlusal patients. Those patients' mandible sit further back, crushing the airway, making it smaller, more difficult to breathe, especially at night. So talk to your patients about these findings and how you can relate them to obstructive sleep apnea, and ask them those questions that may help guide you to sending them for diagnostic testing or possibly starting therapy. A little bit about diagnostic testing. So depending on what state you live in, there's a possibility that you can own diagnostic testing in your practice. Some states do not allow dentists to own this, so I would definitely check with your local, again, rules and regulations. There are pulse oximeters, which are simple, easy screening tools. They're kind of like wristwatches that you can send a patient home with that will record the oxygen saturation overnight. And when you get the report and you see that the oxygen saturation is below 90 at any point, there's a possibility that that patient may be high risk for sleep apnea, and that would be a good opportunity to refer them out to a physician for diagnosis. Sometimes we can have in-office home sleep studies. Sometimes we have to refer our patients to sleep centers. Most of the time, if you are treating a patient and you're screening high risk for sleep apnea, you're going to refer them out to a physician. Now, this is a great way to grow your network of physicians. When you're talking to your patient and explaining the risk factors for sleep apnea, you want to send them to a physician that can evaluate them, assess them, and possibly diagnose whether they have obstructive sleep apnea or not. That's when you can call, visit, or connect to physicians and let them know that you need to refer patients to them. When a physician sees that you're referring a patient to them, they will know, number one, that you're educated in sleep medicine, you're looking for sleep breathing disorders, and you're concerned about this patient, and they will have a higher regard for you. And then once that patient is diagnosed, if they are a candidate for continuous open airway therapy, that physician most likely will refer the patient back to you to start therapy. And that's how you can begin to build some physician networks. How are you going to talk to your patients? I have a couple of scenarios where patients that I've seen, conversations that have transpired, and how we developed and guided them through that appointment to seeking therapy and eventually a diagnosis of sleep apnea. So let's talk about these for a little bit. Let's talk about Joe. So Joe has hypertension, heart disease, atrial fibrillation, diabetes, and GERD. Looking at Joe's health history and all of his medications, we want to question these medications and really ask why he's taking them, why changes have been made, and how they are affecting him. In 2014, in Chest Journal, there is a research study that shows a chronic rise in blood pressure during nighttime while you're sleeping increases blood pressure during the daytime. Using continuous open airway therapy reduces the risk of hypertension. So here's Joe's appointment. While reviewing Joe's health history, you notice that Joe's hypertension medication was changed, and he's also taking GERD medication that was added on. One thing you can say to your patient is, Joe, may I ask if you know why your hypertension medication was changed? And then listen to his answer. Really listen. Yes, Joe says. The doctor said it wasn't controlling my blood pressure. Okay, think about that for a minute. And you're also taking GERD medication now. So now you know Joe's original hypertension medication was not controlling his blood pressure well. He had to add additional and different medication, and now he's added on GERD medication. Those are two comorbidities that are linked to obstructive sleep apnea. Joe says, yes, the doctor said I needed to change my diet and lose weight. Okay, so we know Joe has an issue with being overweight. Maybe he doesn't have a healthy diet. His blood pressure is not being controlled, and now he has acid reflux. What can you say to Joe? So, Joe, do you mind if we spend a few minutes talking about the changes and how they're affecting your health? Show your concern. Does Joe want to keep increasing hypertension medication and adding medications that keep treating disorders? Or does he want to look for the root of the problem and possibly treat the cause of all these comorbidities? Talk to Joe about obstructive sleep apnea, how it's linked to his comorbidities, and then guide him toward a referral or testing for obstructive sleep apnea. In this case, Joe had a sleep study with a sleep physician, and we're going to look at his results. Okay, so Joe came back. He had his diagnostic polysomnogram, which is an in-lab sleep study. He had an AHI of 36.9. What that means is an average of 36.9 times every hour, Joe's airway was shutting down and his oxygen was dropping lower than 90%. It took him just about 6.5 minutes to fall asleep, and his healthy oxygen saturation was 98%, but when he was sleeping and that airway was closing, again, an average of 36.9 times per hour, that oxygen dropped to 81%. During the study, he had loud, persistent snoring. His deep delta sleep was decreased, and periodic limb movements were 19.6 per hour. So what that means is around 19.6 times every hour, Joe's legs were moving or his arms were moving. So he wasn't really in a good, comfortable, deep sleep. Delta sleep is a portion of your sleep cycle that usually occurs about 20% of your sleep time, and it is very important for specific hormones to be produced, for cell restoration, and for physical rest for your body. If you don't get enough delta deep sleep, the next day you start to feel very sleepy and it's difficult to focus. After we presented Joe with this diagnostic study, we talked about treating his obstructive sleep apnea with an oral device. So starting Joe on continuous open airway therapy, he was wearing his device for a few months and he started to feel better. He started to sleep better and he started to decrease his medications. In about 2014, his physician retested him wearing continuous open airway therapy. During that retest, Joe's AHI dropped from 36.9 events per hour down to 0.5. Now, a healthy AHI is 5 or less. So Joe now is scoring in the healthy range. Now it takes Joe about 10 minutes or so to fall asleep, which may show us that he isn't exhausted and passing out at night. He's falling asleep at a normal amount of time. His baseline oxygen was the same at 98%, but during the sleep study, when he was sleeping, his oxygen never dropped below 91%. He no longer was snoring. His deep delta sleep increased to 25% of the night, which is a very healthy amount, and there was no more evidence of periodic limb movements. This is very successful therapy for Joe. Joe is very happy, and Joe is still wearing his oral device. Now you have a patient coming in with another questionnaire that they've answered called a stop bang questionnaire. Stop bang questionnaire asks 8 questions regarding snoring, how tired you feel, if anyone has observed you stop breathing during your sleep, if you have high blood pressure, if your BMI is greater than 35, how old you are, what your neck circumference is, and what your gender is. If you score 3 or more positive answers on this question, you're screening high risk for sleep apnea. So this questionnaire was answered by, we'll call her Mommy. She answered yes to snoring, yes that she feels tired or fatigued during the daytime. No one has ever told her they observed her stop breathing while she's sleeping. She does have hypertension. Her BMI is greater than 35. She is over 50 years old. Her neck is not larger than 40 centimeters, and she is not a male. What happened during Mommy's appointment? So she presented for her hygiene recare appointment. When reviewing her questionnaire, we noticed that she has positive response to snoring. And we're going to ask her, do you mind if we review your health history? I see you have a positive response for snoring. Her young son was sitting in the chair beside her, and he exclaimed, "Yeah, Mommy, you snore louder than Daddy." Well, right then and there, you know that this snoring is an issue and well known in the household. So you want to find motivation with that patient. Now, maybe asking her about her snoring, she can feel uncomfortable, but you know now that she snores louder than Daddy, so Daddy must snore as well. So we can possibly ask, is your husband's snoring affecting your sleep? And through conversation and listening to what your patient is talking about, you find out that the couple is now sleeping in separate bedrooms. You want to educate your patient on the pathology of snoring. Snoring is a chronic vibration in the airway. It can come through the nasal airway or the oral airway. The vibration of tissue can actually cause plaque sitting in your main arteries to loosen up, which is not a healthy situation. chronic snoring over years can actually thin the muscle sheathing around your arteries. So snoring is not just a nuisance, but snoring is pathological. Offer your patient guidance on how to improve her quality of life and her health. Talking about the snoring with her and her husband and possibly treating that snoring if she's diagnosed with obstructive sleep apnea as well can not only keep it quieter in the household, bring the couple into the same bedroom again, but also keep them healthier for a longer period of time. So we did direct Mommy over to a physician, and she had her diagnostic sleep study, and she was diagnosed with moderate obstructive sleep apnea. She had an AHI of 18.2. It took her 39.5 minutes to fall asleep. If it's taking longer than anywhere between 5 to 10 minutes to fall asleep, then most people will say they have difficulty falling asleep. It shouldn't really take that long to fall asleep. So that's usually a symptom of some type of sleep disorder. Her baseline oxygen was only 90%, but still within the healthy range. But when she did her sleep study, her oxygen saturation dropped down to 83%. She had heavy snoring, absolutely no slow wave delta deep sleep, and she was severely deficit in REM, rapid eye movement sleep, which is sleep when you dream. She also had evidence of cardiac arrhythmias. After treating our patient with continuous open airway therapy, she then went back to her physician and we did another sleep study wearing her oral device. Well, her AHI dropped down to 5.1. Now remember before we said anything 5 or less is within the healthy range, but 5.1 was pretty close. Also, her sleep latency decreased, so now she was able to fall asleep quickly. Even her baseline oxygen in the daytime increased to 96%. Her oxygen nadir, which is the lowest oxygen saturation overnight, was 93%, which is still in the healthy range. That heavy snoring actually decreased and became scattered, mild snoring, and her slow wave deep delta sleep increased to about 19%. About 16%. She now has normal REM stage and no longer any evidence of cardiac arrhythmias. So sleeping during the night, getting more oxygen, less snoring, feeling better, getting more energy during the daytime, being able to function properly and at a higher peak is what happened when this patient was treated with continuous open airway therapy. Another type of questionnaire we talked a little bit about before was the Epworth Sleepiness Scale. This patient we're going to call John, and John actually fell asleep during his cleaning appointment. John's Epworth Sleepiness score read as follows. When John's sitting and reading, he has a very high chance of dozing off. When John is watching TV, he has a high chance of dozing off. If John is sitting inactive in a public place, he has a moderate chance of dozing off. Now, if you're sitting in a public place and you're starting to doze off, that can possibly mean that you are very, very sleepy. When John is a passenger in a car, usually for over an hour without a break, he is guaranteed to fall asleep. If he lies down to rest in the afternoon, he will fall asleep. Even if he's sitting and talking to someone, there is a slight chance that John will feel sleepy and doze off. Sitting quietly after lunch and not drinking any alcohol, he had a moderate chance of dozing. And in a car, just stop for a few minutes in traffic maybe or at a stoplight, he never did feel sleepy. So John's Epworth Sleepiness Scale came to 17 points. 17 points is in the abnormal range, and it screens you very high risk for obstructive sleep apnea. So during that hygiene appointment, John falls asleep while we're scaling. John, open please, John, my fingers. How many times has this happened to you if you're treating a patient? John, are you sleepy? You look in his health history, but there were no positive responses, no comorbidities, nothing that would really make you think that he would screen high risk for sleep apnea. But when you looked over his Epworth sleepiness scale, you noticed that he scored 17. Then you look further in his mouth. His uvula is inflamed. Could that mean that he's been snoring and that uvula has been vibrating constantly? When he woke up during that scaling, you noticed he woke up to a little snort, a little gasp. That is a symptom of obstructive sleep apnea. So again, let's ask permission. John, you have been my patient for many years. Can we please spend a few minutes talking about why you fell asleep during your cleaning? And then you're going to find motivation as you listen to John and listen to talk to him about his daily activities and why he's possibly feeling so sleepy that he can fall asleep while his teeth are being scaled. John tells you that he generally needs to nap often in the daytime because he's such a light sleeper at night, and he needs to build up more sleep during the day. He also misses spending time with his son after school because of the constant napping after work. So talk to John a little bit about his family life and his daily lifestyle. John, what would it be worth if you slept restfully and were able to sleep well, wake up more rested, and have more energy during the daytime? Well, it's important for John to spend time with his son. He doesn't want to miss his baseball games after work, so he wants to sleep better. Talk to him about the relationship between snoring and obstructive sleep apnea. We referred John to a sleep physician, and he had a diagnostic polysomnogram in the lab, and his AHI was 23. During his REM cycle, the deepest sleep, his AHI increased to 49. His RDI, which is his respiratory disturbance index, was a little bit higher at 37, and then during his REM cycle, 56. It took him about 5 minutes to fall asleep in general. His daytime oxygen was 96%. However, the lowest oxygen that dropped during that night of the study, the oxygen went down to 70.8%. His Epworth sleepiness score when he did the diagnostic study was about 14. He did not have any deep delta sleep at all, and his REM stage was only 15%, which generally should be about 20 to 25%. John started wearing continuous open airway therapy, and his AHI decreased down to 0. His RDI, 0.4. It still took him only about 5 minutes to fall asleep, but his nighttime oxygen never dropped below 90%. He now is no longer feeling sleepy in the daytime. His Epworth sleepiness scale only scored a 3. His deep delta sleep increased to 18.3%, and his REM stage stayed pretty similar, a little less at 12.4%. This is very successful therapy for John, and John now is no longer napping and able to enjoy his later afternoon activities. What about incisal and occlusal wear? Do you have a patient who is wearing down the biting surfaces of their teeth? In the Journal of Dental Sleep Medicine in 2014, a study showed that the body's defense against the airway closing down was to grind and clench their teeth at night. As the airway closes down and you don't have enough oxygen, your body will create clenching and grinding to awaken the muscle tone and open the airway. So anybody that has any signs of incisal and occlusal wear should definitely be screened for obstructive sleep apnea. So let's talk about Mary. Mary has temporomandibular joint dysfunction. During your examination, you see the occlusal wear and you palpate her muscles, and the masseter muscles are tender. You ask permission. Mary, I'm concerned about the wearing down of your teeth. Do you mind if I ask you some further questions about this? Mary says yes, she clenches, and she has a very stressful day and fragmented sleep. That's probably why she clenches her teeth, is what Mary believes. Well, you want to correlate those symptoms with a sleep-related breathing disorder. So is Mary possibly clenching and grinding because she's trying to open her airway at night? We're not sure, but this is a good opportunity to screen Mary for obstructive sleep apnea and ask her, Mary, if we could reduce that soreness that you feel in your cheek muscles, and if you could sleep better, wake up more rested, do you think that that would decrease your stress? Well, it might. So we refer Mary for a sleep study, and she gets diagnosed with obstructive sleep apnea. She starts wearing her oral device, and she does very well. So not only does that oral device help Mary's airway stay open and breathe better, but it now protects her teeth and prevents them from being worn down any further. And just a little quick note on people that show signs of incisal and occlusal wear. There is a recent study that has just come out. If you're wearing an occlusal guard for grinding and it's covering one arch, it can possibly make your obstructive sleep apnea worse. So any of your patients that are wearing occlusal guards or showing signs of this incisal and occlusal wear, definitely please screen them for obstructive sleep apnea and encourage them to be tested. Let's talk about Sam. Sam has class 2 occlusion. During your hygiene visit, you're checking all of these areas during your clinical examination. You notice she has periodontal disease. She has a Mallampati of 4. So a Mallampati is measuring what you see in the airway. And you can research this a little bit more. What you'll see is that people that show less of their airway when they open their mouth are higher risk for obstructive sleep apnea. So this Mallampati score was 4, which is the highest that you can score. She has a very large tongue, and she has some occlusal wear and incisal wear as well, and she has dry mouth. So thinking about all these clinical findings, what are you going to do when you talk to Sam? Well, you find out during your routine periodontal charting, pocket depths are increasing. Now, Sam is a 60-year-old male, and he's a mouth breather, so he has that dry mouth. Ask permission. Sam, I see your pocket depths have increased since your last hygiene visit. May we talk about this a little bit more? Explain the relationship between periodontitis and inflammation and obstructive sleep apnea. In the Journal of Dental Hygiene in 2013, they showed a significant association between obstructive sleep apnea and increased level of systemic inflammation. If the patient is also snoring, that can cause dry mouth. All of this can develop into higher rate of plaque buildup, caries, and also irritation in the mouth, and is definitely high risk for sleep apnea. Evoke confidence in Sam and your relationship. Sam, Dr. Sleep, or whoever you're working with, treats several patients that have periodontal disease and sleep apnea. Explain the correlation and the connection. Offer testing for obstructive sleep apnea to improve the outcome of any periodontal therapy and the oral hygiene in the future. What have you done by bringing all of these tools into your practice and learning about ways to talk to your patients and screening them for risk factors for obstructive sleep apnea? What you've done is you've created a culture of health and wellness. You've identified risk factors for sleep breathing disorders. You've educated your patients, and you've made them aware of the importance of sleep and its relationship to comorbidities, sleep hygiene, physical and mental health. You've provided rationale for sleep testing and referrals, and you've made it easily accessible to better improve their sleep hygiene, offered them medical therapies, tools, and resources for support. When you get back to your office, talk to your team and develop that practice manual together. Everybody should have an opinion on how you're going to perform tasks when it comes to dental sleep medicine. Create policies on your appointments, on how much time you're going to allow for each appointment, what you need to review during those appointments, who is going to play which role in your practice. Get additional training and make sure everybody, the whole entire staff, is trained and educated in dental sleep medicine. Review your protocols, how you're going to talk to your patients, if they're new, if they're existing, what procedures you're going to use, how your recalls are going to develop, where your referrals are going to go to, what type of testing are you going to do. What are your expectations? Are you going to start with one patient a day? Are you going to screen every patient? Set goals for production. And then as you treat your patients, ask them for testimonials. Ask them for their opinion on how well you did and what you can do better, and all work towards successful outcomes. This is a sample continuous open airway therapy protocol that I've used for many years. What we do first is, after we screen our patient high risk for sleep apnea, we refer them for testing. Generally, we refer to a sleep physician. Once they see that sleep physician and they have a diagnosis of obstructive sleep apnea, if that sleep physician feels that they are a good candidate to wear an oral device, that physician will give us a prescription for an oral device. Then we can begin continuous open airway therapy. During the consultation, it may take anywhere from 30 to 60 minutes. We're going to collect all our records. We're going to decide if that patient is a dental candidate for continuous open airway therapy. We'll go over insurance and finances. They will consent for therapy. It's important for them to sign a consent form for that because you are treating a medical condition. You will take impressions and bite registration. They will return for that device delivery. Generally, our patients will have a few follow-up appointments, seeing how the dental device is working, how they're feeling, how their symptoms are changing, taking care of any side effects that they may have. Then we will refer the patient back for objective data collection, which would be another possibly follow-up sleep study with that oral device in their mouth. Then they will come back to us, and then we will continue to see them generally on a 6-month to annual basis. It's very important for the patient to continue the connection with the sleep physician and the dentist. This is just a sample of our intake form. When a patient calls, the questions that we ask and the information that we need to start treating that patient. You can develop this on your own, or feel free to use this one as a sample. Most importantly, it's all about the team. So educating your team, getting everybody together, getting everybody on board, your reception, your clinical, what you're doing for screening, how you're recognizing your patients, how you're educating them and educating yourself. Then you're going to get that confirmation by the dentist. When you have your findings, presenting them to the dentist, to your patient, and making recommendations and creating a plan of action. And then as your patient leaves, emphasize your findings, survey that patient on if they're going to move forward, how you're going to work with them to treat any kind of disorder if they may be diagnosed, reviewing financials, scheduling, and possibly referral. Never let that patient leave your office without a follow-up appointment, whether it be 6-month, annual, whatever it is. You want to make sure that you're going to follow up with that patient so that you can know the outcome. Develop your team together. Everybody should be part of this team. It's not just about the dentist or the boss or the owner or the employer. It is about the whole entire team getting on board. Assume leadership roles and lead by example. Define your vision and share it with everybody. Have team meetings, have those morning huddles, discuss options for treatment, and everybody's opinion counts. Really understand each employee's strengths and motivators. Ask how things can be done better. Monitor that practice progress and hold performance reviews. When you see team members working exceptionally well, make sure that they know that and continue to motivate them to do better. Remember, most importantly, no one cares how much you know until they know how much you care. Okay, I'm going to open up for any questions. First, I'd like to say thank you very much for attending the webinar, and I hope you received a lot of information that can help you with treating your patients who may be high risk for obstructive sleep apnea. Most importantly, I want to say that it is extremely, extremely paramount to screen your patients. Obstructive sleep apnea is so prevalent in America. We really need to take care of our patients, and we're doing a disservice if we're not looking for these sleep disorders. We are right there at the first line of defense. We look in their mouths every day. We have great relationships with these patients. They trust us. We should definitely be part of the whole entire healthcare team. All right, so now let's look at a few questions here. I see, here's the first question. This is a good question. How can we start our first patient on Monday morning? Well, what I would recommend is first look at your staff, look at your team, and screen yourselves. And if anybody in your office staff screens high risk for sleep apnea, go get tested and make yourself an oral device and get the feeling of wearing it and how it can change your life, your symptoms. Give yourself your own story. And then existing patients, pick one a day during your morning huddle and talk about their medications, their comorbidities. Try to relate that to sleep apnea, and then talk to one or two physicians in your area and let them know that you are starting to screen for obstructive sleep apnea and you need a place to refer those patients to for diagnostic testing. And you will build up a relationship very quickly there. Next question, how will I build relationships with physicians? Okay, this is a great question. So just to finish off what I was saying on the last question, taking your patients, your internal existing patients, screening them for sleep apnea, and then referring them to referring them to physicians in your area. Go to a few local physicians in your area and tell them how you're starting to screen your patients. Present a few cases and let them know that you need a place where you can work with a physician in treating obstructive sleep apnea. Talk to them about oral devices, talk to them about continuous open airway therapy, possibly bring a demonstration model to show them, explain what it does. You'd be surprised, a lot of physicians aren't aware of this alternative therapy, so you can actually educate your local physicians and If they see that the treatment that you're doing is successful, they will continue to have that cross-referral relationship with you. And the next question, what is the best oral device to use? This is a very, very good question. So the answer is there is no best oral device to use. Every patient is individual. Just like there's no one treatment plan for every patient, there's no one oral device for every patient. There's over 160 FDA cleared oral devices that are able to treat obstructive sleep apnea and covered through medical insurances. What I would do is I recommend calling multiple oral device manufacturers. Ask them to schedule an appointment with you to come in for possibly a lunch and learn and show you their devices, show you how they work, let you touch them, feel them, and give you a demonstration model, and then start again with staff or one or two maybe long-time patients making one of the oral devices and get comfortable using them. Again, some oral devices have soft liners. They're great for people with crowns and bridges, any kind of porcelain. Some oral devices are made for bigger mouths, smaller mouths, depending on how your patient's mouth moves, what type of teeth they have, how if they have that dexterity to place the device in their mouth and remove it. So definitely use your oral device manufacturers. They're a wealth of knowledge. They'll show you the different types, and then with your dental education, you can match that device to the specific patient. Okay, well, I'd like to thank you for sitting through the webinar. And if there are any more questions, I'd be happy to answer them. Hopefully that you get excited about dental sleep medicine, start treating patients, start screening first patient, next morning that you start working, and go from there. You may really see that saving lives is so rewarding, and hearing these patient stories can actually change your own life. Good luck and thank you.
Thank you, Gina, and everyone for your questions tonight. Unfortunately, we've run out of time, so any unanswered questions in the Q&A box will receive a reply by email in the next few days. You will receive your certificate of completion for tonight's event in about 2 weeks. For other CE opportunities, please visit www.dentallearning.net. Thank you all, thank you SomnoMed, and have a great evening.